So tonight, I want to start with a question that's really been on my mind for over a decade. I've carried it through clinical practice, through running startups, all of my work at Oracle. And one of the things that I just don't understand is, why do smart people with good ideas, well-funded teams, and genuinely compelling technology still fail? Because they do fail, and they fail at rates that are astronomical compared to other industries. In other industries, it would be completely unacceptable, right? And we also don't like to talk about things like that at conferences like this, because we're looking forward and we're trying to be very positive. But the teams you're going to hear from today in the pitch competition, they're working on real problems. They're working on things that are going to change patient care. That changed everything. But I've spent my time in these systems trying to understand them. And these are the systems that these startups are entering right now. And what I've seen is this: the ideas that scale are not necessarily the best ideas. The ideas that scale were designed to succeed inside the system that exists, as opposed to the system we wish existed. So let me describe something I like to call the digital health graveyard. Every major health system has one in North America. You don't tour it. There's no sign for it. There's no plaque, but it exists in every single IT portfolio, in every executive's institutional memory, and in every doctor's mind who is told, hey, would you try this for 90 days? The graveyard is the collection of proof of concept projects that showed genuine improvement. They either helped patients, they helped providers, and by week 1, 2, 10, 12, things looked really great. But by month 3 to 4, when everyone was very hopeful, there's a big gold star there. But for some reason, it went exactly nowhere. And we've all seen our startup friends do this. And the graveyard's much bigger than you think. And the most disorienting thing about it is that everyone who has buried something there is still a big fan of that technology. Because in most cases, the tech actually worked. The science was sound. The pilot data was amazing. Everything looked wonderful. However, the technology is not the problem. It was the ability of the institution's capacity to actually absorb that technology. That's the real problem. And what's buried there is not bad science. It's not a gap between good tech and bad. Instead, it's a technology that survives this. That is the technology that has that program around it that makes it adoptable. And again, two different things, launching and releasing your new product, because the launch really improves how this adoption happens. So tonight I'm going to give you the clinical realist map of the gap. And before I do that, I had a wonderful introduction. I really appreciate what you've done. But why should you even listen to me tonight, other than I have this microphone? Well, I'm a trained surgeon, and I've spent my entire career actually in the tech sector. So I moved from being a burn surgeon to being in charge of product development for several different startups, mid-sized health tech companies, and then I was at Oracle building out their cloud infrastructure for life science and healthcare around the world, working with ministries of health all over the place, and then helping them acquire Cerner. And after that, well, I got to be the person that not only has been the vendor, but I've also been the person that's been in the delivery system, trying to decide if we're going to work with a vendor. So I've been on both sides of that table. I've been the one that had to give good news, and I've been the one that's received the bad news that my startup was not going to get the funding we were hoping for. So when I think about this perspective that I'm about to give you, it's not theoretical. It's the best perspective you can have for this problem, because it takes into account both sides of the problem. So I'm going to start with a definition problem. In most industries, scaling means growing revenue. You find more customers, you replicate the process, the margin improves, the product's the product. Wonderful, let's just get more customers. In healthcare, that's actually not what scaling means. In healthcare, scaling means changing what happens in a clinical encounter at the scale that you want it to without breaking the system that's already running at 110% because real patients need care today. That's a different problem. And when you understand that, you start to understand why that graveyard we've been talking about exists. Now let me introduce you to the adoption cliff. Now, the adoption cliff is not a failure of innovation. It's a structural feature of how healthcare operates. And here's how it plays out. Startup builds an amazing, genuinely useful pilot program. They run the pilot works, the data is clean, the clinicians who participated are absolutely enthusiastic, the innovation committee does their whole nodding thing, and then there's a moment at that 3 to 4 month mark where everyone thinks it's going to succeed. And it doesn't. The pilot ends, the startup is asked to wait for the next budget cycle, the clinical champion who has been fighting for you tooth and nail gets promoted to another department, and then what happens? The technology quietly disappears. 18 months later, as a startup, you still have no contract that you were verbally told you were going to get from that healthcare system. And unfortunately, this is the median outcome for a health tech startup today. So how can you get past that? Well, we need to understand how the health system actually operates, because what looks like a single failure in this regard is actually 3. The first one starts before the pilot even starts. Clinical workflow in a hospital is not just a process. It's a biological organism. It has evolved over years to handle absolutely impossible constraints. Too many patients, too little time, too much documentation, too many handoffs, and the underlying responsibility that if you do something wrong, people will be harmed. That organization is an organism, and it does not make room for new technology just because. Clinicians do not change their workflow for technology. Technology must fit into the workflow that already exists, or it stalls, or it stops. So here's a practical test. The average primary care physician spends 8 to 12 minutes on their patient. That includes seeing the patient, preparing for the patient, documenting after the patient has gone, all the things, 8 to 12 minutes. So the question for your product needs to be not does this work, but does this fit inside 8 minutes? And does it help or does it hinder? If you can't answer that question precisely, with evidence that actual clinical care is improving, you're probably not ready to scale. You have a demo, but a great demo is not the same thing as a deployable product. Now imagine you know about this workflow and you've been working through it. You've done the work you've designed for that 8 minutes with the patient. The clinicians use the tech and they actually like it. You've earned the pilot outcomes. Wonderful. Now you're about to hit the second wall. Now, I didn't invent this word, but I use it all the time. Pilotitis. You laugh now, but you'll get it. Pilotitis is the chronic condition most health systems have about doing pilots again and again and again, because a pilot feels like progress. A pilot generates data and it keeps options open. It actually satisfies the innovation committee's mission at a hospital system. And so it shows that you're doing something. But most pilots don't actually go into production for long periods of time. A pilot is not a sale. A pilot is a delay mechanism. And I'll say that more clearly. A great pilot by itself is not a sale. It's a delayed no with data as an appendix. The health system has learned something. They've generated a great amount of 90 days of data, and they've paid little to nothing because usually the health system gets that startup to pay for it, right? And then what does the startup have? 90 days of data and a verbal promise. Those aren't equivalent positions, are they? So for the startup, the goal is not to run a great pilot. For the startup, the goal is actually to make the exit from a pilot to an enterprise contract structurally inevitable. That means designing the pilot differently. You have to do things differently with predetermined success metrics. You need to make sure that your stakeholders above the clinical champion are on board. And you need a financial model that demonstrates to the health system that if they do not continue with you, they're leaving money on the table. And most startups don't design for that. They design for the best possible 90 days that could ever occur. Unicorns, puppies, rainbows. And then they discover that those 90-day outcomes by themselves are unfortunately not what triggers a yes. So you solve the workflow problem, you design the pilot with real exit criteria, and you've gotten your enterprise contract signed. I mean, really, that's the best thing, right? And now you're inside the system. And you're about to lose the whole thing for a reason you didn't even see coming. Every health technology deployment has one internal champion. Now this is a doctor, a nurse, a pharmacist, a head of digital, an innovation committee, whatever it is, who believes in the tech, that advocates tooth and nail in meetings for your innovation. And they serve as a bridge between your company and the hospital system. What that person has is a relationship with you. And when that person leaves the organization, almost always the technology also leaves with them. So this is more acute in healthcare than anywhere else because health system leadership is hard. And as an example, in the United States, the average lifespan of a hospital C-suite executive is 3 years. And so you see this go again and again and again. And the demands on clinical champions are extraordinary because usually they're doing this on top of their day job. And when they go to that new position at the director level, they rarely can save budget to keep your technology in place. So I want you to picture a specific scenario. Your clinical champion has been fighting for you for 18 months. They've cleared the procurement hurdles. They've trained the team. Your tech is embedded in the workflow. It's working. And then they take that new position. You're now starting from scratch. Because scaling means building a system dependency, not just a personal dependency. The question is not who is your champion. The question is, if your champion leaves tomorrow, would the technology survive? If the answer is no, you're probably not ready to scale. You have a relationship, and relationships, unlike products, are not repeatable. So we have the workflow wall, pilotitis, the clinical champion problem, 3 structural failures, not 3 edge cases, because these happen all the time. And they're a feature of how healthcare systems will still be dealing with the next startup that comes, because the next startup that gets their pilot will go through this same process, unfortunately. So the adoption cliff is real. What I want you to understand, though, is it's also not the hardest part. In any other industry, the business model is actually something you choose and you design it. You build a product, you identify the customer, you choose your business model, you ask for money however you'd like. In healthcare, the business model is actually not a choice at all. Again, another biological constraint, if you would, built into the system. And if you build your product without understanding that constraint, you're building for a market that doesn't quite exist yet. So what do I mean? Healthcare has a structural feature, unlike almost any market in the world. There's 3 different parts of it. The entity that uses the product, the entity that buys the product, and the entity that pays for the product are different. The patient or the clinician is going to use that technology. The healthcare administrator is going to buy that technology. And then the payer, whether it's the government or private pay, is actually going to pay for it. And most health tech companies, they choose one and they focus on it. And the ones that scale them, they design for all 3 from the beginning. And while that sounds obvious when I'm standing up here, it's completely under-executed in practice. So a startup that designs primarily for the patient experience without understanding what the physicians actually need from that information in order to purchase it are gonna be stuck. You're gonna hit a wall that no amount of excellent technology can actually get you through. So here's the part that nobody tells you in the pitch competition briefing. The reimbursement problem is not a stage 3 problem. It's a stage 0 problem. So let me give you a quick primer, because I know everyone in this room is, first of all, falling asleep, and second of all, not excited about reimbursement in the US and Canada. But in the US, the commercial insurance system reimburses clinical services with CPT codes, so current procedural terminology. Every clinical service, every procedure, every anything, it has a code, you get reimbursed. Wonderful. If a code doesn't exist, or if the payer policy excludes it, the service is not reimbursed at all. So a single CPT code or a change in coverage in the policy for an existing one can actually sink an entire product line overnight. I'm not being that dramatic here. You know, I've watched digital health companies do this. They build an amazing product, it's not covered by Medicare, they try to make it work anyhow, and then the grants run out. And when people can't pay in cash, all of a sudden there's no space for that product. The economics have to work. Now, reimbursement strategy is not something you hire a health economist for in year 2. It's something you have to build into the product specifications, and you have to write them in before that first line of code is actually written. That sequence actually matters, because when you get it backwards, it's very expensive as a startup to do that. Now, Canada is structurally different, and for those of you building here, it matters, because Canada is more of a single payer system, and also managed very much so at the provincial level. So there's no CPT codes. But coverage decisions are made by provincial health ministries and regional health groups, and the process for adding a new service to the covered benefits is slow, more bureaucratic, and more consensus-driven than the United States. So, big barriers on both sides. No one would like to pay for healthcare. Nobody. And that can sound discouraging, but here's what it means for scaling. In Canada, when a coverage decision is made, it actually applies at scale immediately. So a US startup might spend 5 years negotiating contracts with private payers, with hundreds of different commercial private payers, whereas a startup that achieves provincial coverage in Ontario all of a sudden has 16 million patients it can actually work with. Amazing. So the path is harder, but the cliff is much lower. So founders who understand that trade-off can really use the Canadian market strategically. So what does it mean in practice to treat reimbursement as a phase 0 design constraint? It means that before you finalize your product design, there's several questions you're going to really have to ask. Who pays for this when the pilot funding runs out? Not who thinks it's valuable, not who's satisfied. Who's writing the check? Who's paying for it? In year 2, when the grant's gone, who's going to fund this? The other piece is, what's the billing pathway in year 2? Not year 5, year 2. So what code gets submitted? How does it work? Under which payer policy? If there's no billing pathway, well, what's your bridge? Because you got a lot of work to do. And if there's no reimbursement pathway at all, again, what's the willingness to pay? Because if folks are paying with cash, I don't know a lot of people who would like to pay for their healthcare in cash today. If you can't answer these, you've identified your next 6 months of work, truly. Not product development, business development. Because the best product in the world doesn't get adopted without the financials making sense. So I want to leave this part of my talk with a principle I come back constantly. You are not building for the healthcare system you want. You're building for the healthcare system that exists. And the healthcare system that exists has fragmented electronic medical records. It has overworked clinicians. It has conservative payers. And the procurement cycles are slow. And leadership teams that have been in this situation year after year are burnt to a crisp. So they are definitely skeptical every time you walk through their door. At the same time, the system is treating millions of people every day. So they're doing something right. And the innovations that scale are the ones that respect that work within those constraints, and make the system incrementally better, more capable, rather than asking it to become something different overnight. That is not a counsel of despair. Instead, that's a design brief. You have to design for the existing system. Now, I want to spend a couple minutes talking about something generally unexplored in health innovation conversations, particularly relevant for a room of professionals on both sides of the border. The structural challenges I've actually described here, the adoption cliff, the reimbursement issues, the workflow constraints, they're not uniquely American. They're not uniquely Canadian. They're properties of any health system that's old enough to have developed institutional habits and are big enough to make those habits really hard to move. But the terrain's different on each side of the border, and if you understand the terrain, you can actually use it strategically. So let's start with what's shared, because understanding the commonalities will help us understand what the differences are that actually matter. So both systems are fighting the same EHR fragmentation problem, electronic health records. The United States has Epic, Cerner, a bunch of regional stuff, huge tail. And they don't talk to one another reliably at all. Now, Canada tends to be a bit more fragmented at the provincial level with a patchwork of legacy systems. In both countries, getting your technology to integrate cleanly with the existing workflows in that electronic medical record is simultaneously a technical problem, a political problem, a procurement problem, and an enterprise sales problem. If you wait, you'll be in trouble. You have to solve it at least once, because you have to make sure that you have a defensible position. Defer it, and you'll be essentially vulnerable at every sale. Both systems are also fighting the same regulatory timeline push. The FDA in the United States and Health Canada are both requiring clinical evidence of huge amounts. And both processes take a lot longer than founders planned for every single time. Both require investment in regulatory strategy, and many early stage companies don't have the funding to do that, and so they wait to the absolute last minute. And I've watched this deferral cost a lot more the later you wait. And both systems are also fighting something that doesn't get enough airtime in innovation circles, and that's provider burnout and change fatigue. The clinicians who use your technology have spent the last decade being told that this year's digital transformation will fix last year's digital transformation. Their tolerance for new tools is low, and it's not because they don't care, it's because they're exhausted and they've been failed many times before. The innovations that succeed, they're gonna be the ones that reduce burden before they request adoption. Now let's talk about the differences, and specifically, where they actually create opportunity for founders in this room. The regulatory triangulation argument is real and underused. If Health Canada grants your product or device license first, your FDA pre-submission is actually going to be a ton easier. You're going to have the data. It becomes more substantially efficient. And when you arrive with real-world data from a comparable health system, an environment where it actually matters, that evidence is credible to US regulators in a way that preclinical data is not. Now, founders building in Canada who treat the US market as something to figure out later, they're leaving a specific, measurable, strategic advantage on the table. There's also a market segmentation opportunity that's easier to see from this side. So some categories that are generally completely overcrowded in the US are actually underserved in Canadian markets. So remote patient monitoring is a good example. There's hundreds and hundreds of RPM companies in the US, but there's plenty of places within Canada that could really use that infrastructure. The same product deployed first in a Canadian province with relatively little competition can build the evidence base and then hit the US market a million miles a minute. And on talent, I want to be very direct about this because it matters for everyone here. Canadian health AI and health technology talent is world-class. The institutions here are excellent. And compared to San Francisco or Boston, when you have your company here, you will absolutely have more runway. And runway is life for a startup. And that's not a minor consideration at all. That's a big deal. Canada's provincial structure actually also creates something generally useful: a bounded environment, a manageable deployment place. A single Ontario health region is large enough to generate statistically meaningful outcomes and enough information for your study without having to navigate insane political environments, without having to get 200 salespeople for your place. For a company building its evidence base, that's a real asset. So here's the bottom line for founders in this room who are building. Stop thinking of the US-Canadian border as a complication or as a border. Start thinking of it as a design feature and consider how you can strategically use it for opportunity. The most defensible position in healthcare right now is one where you have clinical evidence from real-world deployment, a regulatory pathway that is already established in at least one jurisdiction, and clear reimbursement strategy as well. A cross-border strategy, done well, lets you actually build all of these simultaneously. And that's not twice the complications, that's half the risk. So I want to give you something very concrete to leave with tonight. I've spent years watching health innovations succeed and fail at the adoption point. The companies and products that move from pilot to scale, they share a recognizable pattern. Not one or two characteristics, a full pattern. So let me describe what that looks like from the inside out. So first, the first thing you're going to notice about startups that are in that space is they talk about clinical workflow differently. They don't call it a pain point. They call it a design constraint. The answer to how does this fit into a clinical encounter is precisely known. It's in the product specifications, it's documented, it's measured. They know how many clicks it's going to take. They have built for it. They can tell you with specificity all those different pieces. And they know how it's going to integrate into the existing electronic health record and what the implementation lift is actually going to look like. They actually had figured that out before they even started coding. And that specificity is not accidental at all. It means someone on the team spent time in a clinical environment understanding the workflow with real human beings to make sure it was going to work for them. The second thing is that they can tell you what the billing pathway looks like in year 2. Not we're working on it, not we'll cross that bridge when we get there. A roadmap. They know which codes apply, which payers are going to give them a hard time, which ones they need to influence, and what evidence they're going to need to make it happen. They've budgeted time and money to deal with regulatory and reimbursement work. It's on their darn Gantt chart. It's written down. And this is the clearest single signal that a team understands the system with which they are actually working in. It tells you they didn't start with a product. They started with the system first and built a product to solve a real problem. The third thing is a mindset shift that's harder than it sounds, particularly for founders with academic backgrounds. I know we have a lot of people in here that are academic founder backgrounds. Clinical evidence tends to be designed for journals. But what you need to do is design your clinical evidence for the economic buyer, not just the journal. A peer-reviewed publication is not what's going to get a health system to sign. What makes a health system sign, instead, is evidence that directly answers questions that the C-suite has. Does this reduce cost? Does this reduce clinician burden? Does this improve a metric the organization has been following? The companies that scale design their clinical studies to answer those questions too. The fourth thing is identifying the economic buyer. And this is before they recruit the clinical champion. I know people are going to start throwing tomatoes at me. Who signs the check? In a health system, that is rarely the physician who is championing your product. It's a CFO, it's a VP of procurement, It is a system head CEO. The companies that scale knew what that person needed to see, what their budget cycle looked like, and the 3 metrics that they cared about before they built their first line of code. The clinical champion will open doors. The economic buyer writes the contract. Both relationships are necessary, but only one triggers a yes. And it's not the one most early stage companies spend their time on. So your clinical champion, they're gonna fight for you in the hallway. They're gonna be in the committee meetings. They're gonna help you through that procurement process. And that advocacy is real and it matters. But the champion fights. The economic buyer decides. You need both. You need to earn them in the right order, and you need to understand that they're not persuaded by the same things at all. And then the last thing is, and this is what founders get wrong most often, their scalability is organizational, not just technical. The technical question of moving your product to 10,000 people or 1 million pieces of people, I mean, if we have the right cloud architecture, I'm sure we could do just about anything technically, right? The organizational question, though, is harder. Can the health system that you're working with actually implement this technology with their existing people, with their existing processes, and their existing change management infrastructure? Health systems do not have infinite implementation time. They're running dozens of technology initiatives simultaneously. You are not their special snowflake startup. And your product is going to go into a queue. If your implementation requires 6 months of staff training, a dedicated project manager, and weekly vendor check-ins, you're not building for the system that you're in. You're building for a system with capacity that it does not have. The companies that scale build for low implementation as a core design principle. And they make it easy to say yes. And then they make it even easier to stay. So workflow fit, treated as a spec. Reimbursement, built from day 0. Evidence designed for the buyer. The economic buyer identified before the clinical champion. Organizational scalability, baked into the implementation model. None of these are revolutionary. Sounds pretty easy, right? But all of them are systematically underinvested in by early stage companies because of the urgency of building their product, crowding it out. And instead, there's a lot of work on product and not a lot of work done on the business model. The companies that scale figure this out early, and that's the only material difference between them, those that scale and those that do not. So in a few minutes, we're gonna watch a bunch of teams pitch. And some of those teams are in this room right now, sorry guys. But I wanna give you a lens, not as a reason to be skeptical, but as a way to be genuinely useful to these organizations. Whether you're an investor, a potential collaborator, colleague, or a founder yourself who's watching and learning. When you watch the pitches tonight, you're essentially running a clinical diagnosis in real time. You're listening to hear if this team knows who's actually paying for the product. You are listening to see if they know who's not just benefiting or who's not just enthusiastic, but who's gonna write that check. Because who writes the check after the grant funding runs out is very important. You're listening to hear if they understand where the workflow wall is, where they can describe specifically what changes in the daily clinical workflow. What's going to happen to the real people that are working with every day? Not in the abstract, specifically. And that specificity exists, or it doesn't. And I know it's hilarious. You're also listening for the regulatory pathway. Not we're gonna cross that bridge, like I said before, but a person who owns it, a plan that's been thought through. And you're listening to hear whether they have talked to the economic buyer at all, not just the clinical champion who loves their ideas. Those are two very different conversations. And you're listening to hear how they answer the question of what deployment actually looks like at scale. Not technically, organizationally. What does the customer have to do to make this real? You don't need to have a yes to all 5 of those to believe in a company. Early stage is obviously early stage for a reason. But a team that can't engage with those questions and is telling you something maybe not true or maybe a little squishy, that tells you that perhaps they are not prepared for that piece of the business. So I want to close with this. The clinical skill I was trained in as a surgeon is diagnosis. Before treatment, you diagnose. You do not hand a patient a prescription before you've done all of your work. You gather information. You look for the things that explain all the symptoms, not just the bright, shiny symptom that's obvious. And you resist that pull for a satisfying answer that arrives before you've got all the evidence. The discipline applied to innovation is what I've been talking about tonight. The startups that scale are not the ones with the best technology. They're the ones that did the diagnostic work first. They diagnosed the workflow. They diagnosed the reimbursement constraints. They diagnosed the organizational capacity to adopt it. And they built a product that fits that diagnosis. It's not pessimism. That's precision, that's planning. The healthcare system is hard to change, but it's totally worth changing. And the patients who move through it every day deserve the innovations that are coming out of this room. But we want to make sure that the innovation doesn't just look good in a pitch deck, but actually can be deployed at scale for all the patients who need it. Healthcare does not reward brilliance. It rewards fit. The most sophisticated technology deployed into a workflow, it disrupts. A budget that can't sustain it, and an organization that doesn't have the capacity to actually absorb it is not innovation. It's a very expensive research project. So there's a question I ask every health startup that I work with, and I'll leave it with you tonight. Do you understand the system you're asking to change? Not your product, not your gosh darn market, not your TAM or SAM. I wouldn't want to know any of those. Not your technology stack. The human system, the workflows, the incentives, the decision makers, the change fatigue, and the reimbursement challenges. If the answer is yes, everything else is figure-outable. And if the answer is not yet, that's the most important work you have in front of you. Thank you.